Welcome to PSTM 2025 in New Orleans and a live recording of the PRS Global Open Leveling Up podcast. I'm your host, Dr. Purushottam Nagarkar from UT Southwestern Medical Center in Dallas. Today, my guests are Professor David Chuang from the Taipei Municipal Wanfang Hospital and his nerve reconstruction fellow, Dr. Jing Tay. Dr. Chuang earned his medical degree from Kaohsiung Medical College in Taiwan and completed his internship and general surgery residency at the Veterans General Hospital in Taipei. He did a plastic surgery residency under Dr. Samuel Nordhoff at Changgang Memorial Hospital in Taipei, followed by extensive fellowship training with Dr. Terzis, Dr. Narakas, Dr. Milesi, and Dr. Kondo. He worked at Changgang Memorial Hospital as a professor of surgery until 2024 and then joined the Wanfang Hospital, where he has been for the last year. Dr. Chuang's surgical career has focused on peripheral nerve and brachial plexus reconstruction, including functional muscle transfer for the reconstruction of the face and restoration of function in the extremities. Dr. Chuang is the honorary editor-in-chief of the International Microsurgery Journal, past president of the World Society for Reconstructive Microsurgery, and president of several medical societies in his native Taiwan. He was invited to give the Millenniac Lecture at PSTM 2025 in New Orleans, discussing his 35 years of experience in nerve reconstruction. Dr. Jing Tay is a nerve reconstruction fellow working with Professor David Chuang at the Wanfang Hospital. He trained in plastic surgery in Oxford, England, and also holds a PhD in biomedical sciences and executive MBA. He is the current chair of the American Society of Plastic Surgeons International Residence Forum and serves as the UK's national trainee lead for the Lymphedema Special Interest Group. Dr. Chuang, welcome to Leveling Up.
Thank you for inviting.
Well, it's an honor to have you here. Just an hour or two ago, I was in the theater listening to the Millenniac Lecture that you just gave, and it's truly awe-inspiring to see what you've been able to achieve over the last 4 decades of pushing the field of nerve reconstruction forward and with innovating kind of on a daily basis.
Thank you.
So we have a lot to talk about, but I kind of want to start actually with some of your choices in how you have built your career. Many of us in plastic surgery have, broad practices. We do a little bit of this, a little bit of that, some hand surgery, some breast surgery, but you have had a singular focus, nerve reconstruction from the very beginning. And, interested to hear from you what led you to choosing that specialization. How did you pick that? And what are your thoughts on this idea of being highly focused versus broad?
I think it's a very interesting career. In the beginning, I am not, selective which one I want to go. But after the training, it's such kind, as I mentioned in the meeting, and I know the Manila lecture, I say I have 6 inspired teachers. The first inspired teacher is from the Nodo. He inspired me to be a plastic surgeon. At that moment, I do everything, including the face aesthetic surgery, reconstructive surgery, brief rape. And then moved to the Hussein Wei, the second is inspired teacher. He inspired me because at that moment, Hussein Wei just learning from Canada and come back to my hospital, and he's my mentor. And I saw his microsurgery. So I became interested in the microsurgery. Then, in Changgang, there's a regularly, once you promote as a staff, you are responsible to go abroad to learn new things. At that moment, my mentor, the Nodo, want me to go to Norfolk to learn with the Julia Terzis. The Terzis at that moment is very hard microsurgery, especially focus on the nerve. Then after 1 year's Norfolk training, I came back, I practiced, I found many, many questions in the nerve problem. I think it's still, I'm not enough. The knowledge about the nerves still not enough. So I push myself to contact the European surgeon. This is why I go to the Milesi area. I go to the Nagarkar. The Milesi is Austria. Nagarkar is Switzerland. They actually the opposite. They fight very much. But I'm lucky to visit both sides. 3 months there, 3 months, another 3 months on the other side. I learn, I know, what's the best result from them. Then come back. Then I meet one Japanese doctor, Kondo sensei. and he majority, for the congenital hand, and especially like a polio hand or polio foot. I learned from him about how to reconstruct the paralytic limb patient. So these four international mentor pushed me to concentrate in the peripheral nerve. Peripheral nerve field actually is quite mysterious. Once you get in, it will drop. It will never go, leaving. Because you can see the good result after the surgery. You're happy about the result, which attract me, to continue. This is why I concentrate. After all, I concentrate in the peripheral nerve reconstruction, and especially in the brachioplexus facial paralysis. Of course, in the beginning, I also do many complex peripheral nerve injury, such as compartment syndrome. So this is fine. I have a fellow, domestic fellow in Chang'an, Tommy Zhang and Johnny Lu. They also like my experience, like me. Once you drop in, it never, it never leave out.
Well, I mean, I feel like peripheral nerve is different from some of the other specialties in that you need more patience to see the results. It takes a long time. If you do a facelift, you see the result quickly, or a breast reduction immediately. With nerves, it's going to take you 3 months, 6 months, a year, 2 years to see what the effects are going to be. So it requires a different kind of patience.
That's true. That's true. I have another colleague with the same level, Hong Ji-chen. Hong Ji-chen, he learned from the Australia mentor, like Ian Taylor or like O'Brien, Wayne Morrison. He learned from them. We're same level. However, in the beginning, maybe the first 5 years, I did not have any paper. But Hong Ji-chen has many paper because I made moment breast surgery and lymphatic surgery, very easy to publish the paper. But I'm doing the nerve. I have to wait the result after rehabilitation. So you have to keep patient. Continue contact your patient. Post-op, follow-up. I think this is patient. You have to keep patient.
Now, philosophically, do you think that as plastic surgeons, we should all be more focused on one specialty, one subspecialty? Or, do you think it's okay to be kind of broad? Do you think we're better off being more focused? How would you advise your fellows, your residents?
No, I don't think so. To fix in the beginning. In the beginning, you have to go around. For example, the first period, I learned from my mentor, Dr. Nodo. I learned many cosmetic surgery, especially on the face, which gave me a great help because when I perform the facial paralysis reconstruction, you need such kind of the cosmetic surgery technique to improve the result. So I don't I don't recommend you in the beginning pick one field. I think you better go around and to learn more things. Then finally you concentrate one field, like me concentrating the peripheral nerve. But I still use the basis of the cosmetic surgery technique to help me to improve the result.
So you still need those experiences to be able to inform what you do then.
I think so.
Yeah. I want to talk with you a little bit more about the aberrant reinnervation, synkinesis, and the sequelae of all that. But before we get to that, I have some technical questions for you about the different kinds of surgical techniques you use. One of the things I've heard from, all the different people I've talked to about you, your former trainees or people who worked with you, is that you have an amazing ability when you are doing the surgery to be very precise, but also decisive. There's no hesitation. You don't waste any movement. You don't waste any time. You do a very clean, beautiful dissection very quickly. And, I guess the question is, how do you teach, when you're working with Dr. Tay now and you're teaching him how to do that, how do you teach your fellows to do that well? What's what are the tricks you need to know to be able to do a good dissection, a clean dissection in a difficult area like the brachial plexus?
I think the anatomy is essential. If you want to be a surgeon, you should be familiar with anatomy. Of course, brachial plexus surgery, once you know anatomy, there's no danger. To me, it's no problem. So I like to say, of course, anatomy, you need to know that. And the best way is you can do cadaver dissection. When I was in Norfolk, I was lucky because they have prep surgery. After the prep symposium, they leave the body there. And Julia Tersis, my teacher, my mentor, asked me to dissection the whole brachial plexus because he wanted to do the topography, intranural topography. So this time I was lucky because I dissected many more than 20 cadaver. So I, harvest the whole brachial plexus from the beginning, level 1 to the up to in the level 4, as I mentioned, using the number. Then I know the anatomy. So I still say, if you want to do the nerve, the first one you need to know anatomy. So essential.
Yeah, I mean, certainly once you know the anatomy, you can see things before they happen. But looking at some of the pictures, like during the Millenniac lecture, you showed some pictures of a particular patient that you did a brachial plexus exploration, and I was looking at that picture, and that was the most beautiful, clean dissection I've ever seen. There was not even a drop of blood anywhere. Everything was perfect. And I'm wondering how you get such a beautiful, clean dissection quickly, because you do it quickly as well. You're not taking 6 hours to do it, which is, if I was doing it, it would take me a long time. So, do you have particular instruments you like to use? Are there things that you do that are different or unusual, do you think, when you're doing that kind of dissection?
I don't think so. It's not the instrument problem. The problem is because I learn, I have a different mentor. They all are top. They all are top in the world. Dr. Nodo, Hussein Wei, Churches, Milesi, Nagarkar, they're all the top. So I learned from them. So when you do the nerve surgery, you see clean, especially even the Uji, you see to stop them before we do the nerve repair. So I always say, brachial plexus exploration should be generous. Generous means you have wide exposure. However, when you manipulate the nerve, you should be gentle. One is generous. Generous means you get wide exposure. Gentle means you have to treat the nerve like your girlfriend. So then I think of course, you went to do the nerve repair, you should clean the wound, oozing and all stop then people, and then after you do nerve repair.
Yeah, being extremely gentle. The other thing I saw, I think, again, in one of the pictures, that you had a lot of vessel loops around the nerves. Nerves were being pulled up. So is that something you like using vessel loops to pull the nerves up from the field?
Always.
Yeah.
These 3-color vessel loop, the green color and the blue color for the vein, red color for the artery, white color for the nerve. We always will need those kind of 3 vessel loop to to leap up the vital structure, including the nerve.
Yeah, keep an eye on things. With both brachial plexus and facial reanimation, the preoperative evaluation and the planning is critical. And again, you were talking about this during your lecture earlier today. The difficult part with these cases, I mean, everything about these cases is difficult, but the preoperative evaluation, the exam, figuring out what is wrong is often a very difficult thing. And I've noticed that you had a lot of pictures that you like to draw. Is that something you use for creating the diagnosis? Is that something you use for planning the diagrams that you like to draw?
I like to use 2 examples. One is the brachial plexus. They always have a preoperative chart, right side, left side. They including including the history, including the oral study, including the motor sensor examination, including the pain tolerance. You have to complete that before you do the surgery. In those, I don't know whether you know that, or the brachial plexus, they have when you see the textbook Pro Mind, you can see the right side brachial plexus, left side brachial plexus. The paper. You have to finish the paperwork, write down the check complaint, what you examine, and finally, it of course including image study, including the such and such. Then you have to complete that before you do the surgery. This is, I say, preoperative diagnosis is very important. For the facial paralysis, is the same, especially facial synkinesis. I have a special chart, for the I list. When you see in my article, you can see that I list the 5 essential movement and the 6 synchronicities. I always write down on the note, and so before the surgery, because it's good for you to explain to the patient. Explanation is key point before you do surgery. You have to let the patient understand what's your lesion, what are you going to do, and what's the post-operative care. Those issues, the paperwork is important to you, important to protect you also. So those things, I think, called essential pre-operative diagnosis. During the surgery, is immediately after surgery, you need to make a drawing. Those drawing is very key. It's very important because later follow up, no matter 1 year, 2 years, the drawing just simply tell you what kind of surgery you've done and what kind of result you expect. So I think also the note, you have to describe clearly. Operation note, write down on the same paper, same paperwork, and how the post-operative follow-up, also write it down, making the one series, one paper, you will put in the one chart, one folder, you can say, all his history, before, after. I think those things is important.
That's a really good idea, actually. It's an interesting thing because we do a lot of evaluation preoperatively. We might have pictures, but then when we do the surgery, we write a note and it's a description, but often we don't have a picture of what the surgery was.
Yes.
But having a drawing in that operative note immediately afterwards is a great idea. I'm going to start doing that.
I think so.
Yeah, that's a
right note. There's one also from Australia, also mentioned making a note is an important step. Making a note. Yeah.
No, I'm going to start doing that. That's a good advice. That's great advice. So let's talk about aberrant reinnervation and the sequelae of aberrant reinnervation. So specifically the motor version. So you call that MARS, MARS. This is obviously important in facial palsy with synkinesis, for also in brachial plexus with co-contracture. Tell me how your overall approach to these patients is. Do you have an overall philosophy of how you approach these MARS patients?
You're talking about aberrant reinnervation. Actually, original term come from the eye doctor, ophthalmologist, or plastic surgeon. Maybe not not emphasize this, but in the eye doctor, they emphasize the aberrant reinnervation and also the aberrant reinnervation sequel. Aberrant reinnervation syndrome. This is my term, sequel. So actually, the first 2 terms from eye doctor, aberrant reinnervation syndrome. I add aberrant reinnervation sequel. So this is my term. Nobody use this term. So you can see today, I'm talking about once the endoneurium and the sudden streak injury involve the endoneurium, involve the extra, then lateral sproating will come in. It not only cause the motor sensory center motor mismatch, it also cause the motor itself. Not every case, but potential cause. Not every case has such kind of the sequel, but potential you might meet this. And I believe this is the first time you heard MARS, SARS, and UNSARS. I know, that's right, I know. I actually write this article to the PRS, but they not accept it. I reject it. I got the rejected reply. And because, as I told you, the plastic surgeon, one old reviewer, he say he also the perineal surgeon, but he say the first time, and like you heard about this term.
Yeah.
So they reject. And he said, especially like the brachial plexus burst injury patient, he said, I meet many cases, but I don't have such case. I just wonder, because my reconstruction, based on this hypothesis, aberrant innovation. You have to try to do something. Otherwise, you cannot get good result. So as I say, the reconstruction should be aggressive. Otherwise, you cannot get the result. Cannot get good result.
And what do you mean by aggressive? What
aggressive? Let me talking about for example, facial synkinesis. When you see my article 2023 in the PRS, I remove the whole synkinesis nerve and the muscle. I remove. There's a 5 branch, right? TJBMC. I preserve the temporal branch because it's good for the eye closure. I prepare a mandible branch because it's good for the lower lip. I remove all the cheek, nerve, zygomatic branch, back branch, and all the muscle. And also I remove all the platysma muscle.
Oh, wow.
Colibri, I just take it out.
Yeah.
Then you do reconstruction.
Yeah.
And my philosophy is you have to treat the synkinesis first. You have to treat the synkinesis first, then you treat the smile.
Yeah.
My surgical strategy, I have to say my surgical strategy is because I based on the hypothesis of aberrant innovation. So the patient recovery, the facial paralysis recover, but it's not nature. Although they recover, initially the total paralysis then recover. However, the recovery is becoming unnatural smile, unnatural animation.
Yeah.
At that moment, I think the best treatment is reestablish, because the original nerve muscle order is already not natural. I think the best way to take it out and reestablish a new muscle order is aggressive, such like a brachioplexus baby palsy. I also transfer the many, synchronous the muscle to the antagonist muscle become the synchronous muscle.
It's like a flexor becomes
extensor muscle transfer. Right. That's right.
Yeah,
that's right. Nobody could use the elbow flexion to the triceps.
Right.
This is untraditional.
Yeah.
But I think you better do that because tricep is not easy to be reconstructed. I don't worry about elbow flexion. I have many methods can do elbow flexion. So first of all, elbow extension is the first priority, not the elbow flexion. People like to use the tricep to biceps or maybe the Snyder procedure. They don't not good result. Because of that, I'm abandoned.
Right.
So I using the anti-traditional method. I'll transfer the bicep or elbow flexor to the triceps.
Yeah.
Tricep is my first priority.
Yeah.
So this is so aggressive.
Yeah, it's like a paradigm shift, though. I mean, for a lot of people, they're approaching it the other way.
Yeah, that's right.
Toward flexion first, and you've switched that order.
That's right. That's right.
It's an interesting approach, right? Because you're looking at it and saying there's a problem, and instead of trying to just put a Band-Aid on it, you want to rip the whole thing down and start from scratch.
Renew, reestablish.
Reestablish, yeah.
That's right.
I mean, it's kind of one of those things where it's scary to do that because you're taking out more things that are.
I know. It's just because in the beginning, like baby palsy, I mean the co-construction shoulder elbow. In the beginning, I still follow the many orthopedics principle, but I saw the result is not good. We have to think about something to improve. So I do my way. Facial synkinesis is also the same. No matter people talking about hyperselective neurectomy and myectomy and so on, not good. You better remove, all that. Then you reestablish.
How do you restore the platysma function, or you're not? Because I know with the mid face, you're doing a gracilis and you're having it do two different functions for eye closure and smile. Do you try to restore anything that you've lost with the platysma, or you say you don't need that? That's just a synkinetic problem, and we got rid of it.
Actually, these two territory. One is a complete facial paralysis, no synkinetic. It's complete facial paralysis, brain tumor surgery, complete facial paralysis. And the other thing is, after the complete facial paralysis, then recover, become a synkinesis. There are two territories. So we have to separate. We have to separate to discuss. So for the complete facial paralysis, as I say, using the one muscle for two connection. Sometimes I also do the cross vena for lower lip. The the measure of the digastric anterior berry digastric muscle. I do the same thing for the smile and 2 years, depend on the patient request. Especially each patient, the concerned eye, the more concerned I am, than the smile. So at that moment, you can focus on the one muscle, two function, smile and eye closure. Some the children, they lost they don't have the eye problem. Of course, they cannot close eye, but they can adaptive the eye very very easier than the adult. But they're more concerned the lower lip. So at that moment, you can do the digastric anterior belly digastric for lower lip and the crossventral gratis for the smile. So I think this is two territory.
Yeah, that makes sense. I guess with the kids, they don't have as much dry eye, and so they can get away with.
They don't have.
Right, right. When you're doing the gracilis and getting two functions out of it, you have to have a section in the middle which is not functional but has to be intact to allow blood flow between the two sections.
That's great. That's great. That's correct.
How big is that section? How do you decide how much can you cut before you're in trouble?
It's usually no problem. Usually no problem. Under scope, I think you can see my article in the Japanese PRS. I think the first version, the first chapter, because I'm the first also of that. The Japanese PRS in the beginning in the previous, they usually using the Japanese writing the Japanese. Now they move to the English version. So if you read that, I think some detail there. So don't worry. You just look at the articles, you can understand the detail.
Sure. But then the same thing with the nerve, right? I imagine you have to do a intraneural, intramuscular dissection.
That's right. And the concept is come from the Singapore doctor. I think I forget his name. I think Lim. He used intramuscular dissection. LYM in Singapore doctor, plastic surgeon, hand surgeon. I think I think he's the first paper talking about intramuscular dissection of the forearm muscle, become the one muscle become two muscle function. I think the Garchi is also the same. There's one paper talking about the nerve contribution of the Garchi's muscle. It has been done. People has been studied. Maybe I think the 2021 or 22. There's an article talking about the nerve contribution into the Garchi's. But because my dissection, the nerve usually below. This is I say if you look at the article, I always usually dissection the nerve 2 finger below the neuromuscular junction, 2 finger width. The make you harvest the tensor fasciae lata to make a circular sheath. Then below, then you can dissection the nerve. Usually there are 2 or 3. Usually 2. The main branch. You preserve the main branch. This dissection a little bit the proximal beyond the tensor fasciae lata territory, and go up to the entry zone. Then you can cut it. Then you can distally keep dissection until you meet the same. The pedicle. They have main pedicle for the upper side. They also have a small pedicle for the lower side. The same. You just dissection about 2 finger width above the minor pedicle. Then stop. Then nerve on the tensor fasciae lata, another tensor fasciae lata sheath, and like a low border, and the tensor fasciae lata sheath upper border. Then you can get the 2 nerve.
Sounds very delicate and very intricate.
Yeah. You can do it. I think no problem.
Right. Do you do that under the microscope?
Of course.
Yeah.
You need under microscope.
Yeah. With these really complicated surgeries, and you already mentioned this before, talking to the patients and being able to explain to them what you're going to do, is very important. And on the other hand, these surgeries are so complicated. When we're trying to explain them to the residents or the medical students, it's hard. I can't imagine how, so what's your approach when you're talking to the patients to be able to get them to understand what you're doing? How do you approach them? Because this is not simple.
I think it's a good question. Maybe in the beginning, 2 or 3 patients, cannot make a very well complete explanation. However, once 2 or 3 patients, you get a good result, then you make a photo and you make a book in the outpatient clinic. You can show them my technique and how the pre-op and how the result post-op. You also can show them to the patient to emphasize your technique. I think this is one way to try to convince your patient to accept the surgery. Usually they accept because they suffer. They complete facial paralysis, no eye, cannot cross eye, lack of thumbs, cannot smile. So they're eager to have the surgery to treat them. Yeah.
I mean, with these surgeries, I often worry that the patient often wants the surgery more than you want to do it, even because they're, like you said, they're suffering, and you need to know that they understand the risks as well. And I'm always questioning myself when I'm talking to patients about complicated surgeries. Do they understand the risks involved and the difficulties involved? Because it's multiple surgeries, lots of recovery involved. So I just wonder how you explain that. And not all patients are highly educated. Sometimes they're not very
That's true.
educated.
That is true.
Difficult.
That is true. That is true. This is especially true in the facial stagnations. If you're not well explained, you might get trouble. The patient may sue you, especially facial stagnations. So I always, uh, uh, explain to the patient, not alone. You need the witness. I always ask patient family, father, mother, or wife, or husband, come. 2 people listen, and I also make a note with the writing a note. What called the facial signatures, the hypothesis of the facial signatures for the current treatment. I already a note. I give the paper to the patient, and because there's 2 people together, so they go home, they discuss, and next time come, they question me. I try to give him the answer. Then this decision is not made by the patient, the surgeon. It's made by the patient himself. So you need a witness. I said this is very important to protect you. So you make a note. I have maybe I have a 6 special child, Barker procedure, baby palsy. Baby palsy 2 form. One is a nerve reconstruction, one is a tendon muscle reconstruction. There are 2 form, and one is a facial paralysis, and one is a facial and the other is a thoracic syndrome. Thoracic syndrome also have you have to be careful. You have to write it down, and a good explanation. So all those note is very important, and you give the notice the patient bring back to see detail. Any question, just the next time come back again, question to me. I try to fit answer. Yeah, I think this is to convince.
Right. I mean, that's a good point too about thoracic outlet, because compared to a brachial plexus injury or a facial paralysis, with thoracic outlet, it truly is more of a hypothesis. Maybe it's going to help. Maybe it's not going to help. You don't know for sure. Whereas with facial reanimation, yeah, you put a muscle there, it's going to create a smile. You know it's going to work. But thoracic outlet, it's even more complicated in terms of, certainty of result.
I think this question you may ask the Tay, because he already see a couple of cases, the thoracic syndrome patient. Even though after the surgery, the patient originally has hands function, but after the surgery, paralysis hand. I don't worry. I tell the patient, this is due to the suction. It's the neuropraxia. Don't worry about that. Before the surgery, you already can explain. You have temporary neuropraxia. It will come back, don't worry. I also more confident because during the surgery, I protect even the brain nerve. I always brain nerve. I don't want my assistant touching the brain nerve. Otherwise, they will temporary, the diaphragm aviation.
Yeah.
So the dyspnea will occur the day of the surgery or maybe the next. And those things, I think maybe you can tell something, what you see, my surgery, what I explain to the patient, even including the special note.
Yeah, I think what I found amazing with Professor Chuang is he always takes the time to assess a patient, not just once. If necessary, he'll bring the patient back at least 2 or 3 times as follow up in the clinic before he actually pay a lot of attention in confirming the diagnosis before he decide on the treatment. He doesn't just label a patient with a diagnosis for the sake of it, and he always check with the patient and the family, is that really the symptoms you are having, and how does it affect your life? So one of the things that I found with Professor Chuang is it takes the time to understand the patient concerns and what expectation they have in terms of the surgical recovery, what they expect from Professor Chuang, to what function they expect to get back after the surgery. And the second thing is, as Professor Chuang has alluded to, you have to take time to explain to the patient, to manage the expectation, to say that this is what is achievable. For example, if the patient has muscular atrophy after a long-term, as a sequelae of a long-term thoracic outlet syndrome, you have to tell them that you might not, you most likely than not, you won't get the muscle bulk straight away. You go through a period of rehabilitation before you get the strength back, and possibly later down the line you might get some of the muscle control a bit better. And also he works very closely with the rehabilitation department, especially when he was in Chang'an. They work very closely hand in hand to manage a patient to get the strength back, and I think those are the full package really. So I think you have to be very careful to first of all, to make sure the diagnosis is correct before you plan any treatment. And when you do the treatment, take the time to explain to the patient and the family, because they'll be the one that will be looking after the patient, make sure patient is compliant with the rehabilitation to get the optimal results. So I think that's the thing I learned from Professor Chuang.
Yeah, I mean, the compliance thing is a good point, right? There's a lot of rehab with all of these surgeries. It's not a one and done. They have to do the surgery is the simple part. They have to do 1 year of rehab afterwards to get the results, and you have to make sure they stay motivated.
Yeah. You have to take care of the patient post-operative. You always express you concern you, I concern you. And sometimes I bring the rehabilitation doctor come. We discussion. I think the patient see our discussion. And I ask them how to do that, how to put a swing, and the patient understand. We take care of him. I think those things is important. The other thing is if the patient hesitate, don't do surgery. Thoracic syndrome, facial synchysis, facial paralysis. If the patient any hesitate, just stop. No surgery.
Yeah, you don't want to push them.
No, not push them.
Yeah. I want to kind of switch gears a little bit. I want to talk about longevity in as a surgeon. I look at you and I say you've had a long career, 35, 40 years, and you're still going strong. At an age where maybe many of the people you grew up with are retiring, but you're still operating and you're still doing big, complicated surgeries. And burnout is a big thing for surgeons that worry about physical, mental, both. So how do you keep yourself full of the energy that you need to continue doing these kinds of surgeries? Do you have things you do throughout the day or throughout your career that you've done to keep yourself from getting burnt out or tired or injured?
I think that individually, the different surgeon has a different opinion and a different behavior to keep in the body, under the good condition. I think different. To me, I always swim, and go to the swimming pool to swim. I know once I have the muscle soreness or muscle, I no drug. I just go to swim. Each time 1 hour, I think can treat your pain, the soreness of muscle, and those things is of course you need to exercise. You need to exercise.
Do you take breaks when you're operating? There's some people who, once they're operating, they'll just operate for 12 hours, no breaks. And there are other people who will take breaks. Are you the kind of person who takes stops in the middle of surgery, or do you just kind of power through?
When I was young, I just straightforward, no break. But recently, social syndrome is okay because social syndrome usually take 3 hours or 3 hours, usually average 3 hours can finish. So the usually don't need to take break. The pressure part is you need to take break. Function free muscle, you have to take break before you harvest. Or I always ask the assistant take a turn to take break, including me. Maybe they can dissection the cartridge, then I take a break. Maybe they do I usually do auto repair. Then I did the wind repair by my assistant. The 1 hour later, then I take a break. Then I come back to check if everything is okay. Then close the wind. So take time. We also need to take time for the relax.
So you're almost using the break also to kind of give the anastomosis time to make sure that it's staying up, so you don't leave the operating room too quickly.
That's right.
Yeah. So it's a break for you, but also good for safety for the
Yeah. This is why I need the fellow. This is why I need the fellow. This year I have 2 fellow. Yeah, usually I have 1 fixed fellow, 1 year fixed fellow.
So when you look at now the past 40 years, and if you look back forward 40 years, where do you think the future of nerve surgery is? What's Dr. Tay going to be doing when he's in your chair? What is he going to be talking about? What are the changes you see coming?
Usually, if you want to be my nerve fellow, I always call my fellow nerve fellow. If you want to be a nerve fellow, I will ask him to do the research. Because the nerve, you need to do research. The more you involve research, the more you understand the nerve. So this is why I always ask them to research. So this is one, ask them to research. And second thing, ask them to read book. So my new hospital, I have a so-called parent team meeting. Usually, they arrange schedule on the Wednesday, 12 o'clock to 1 o'clock, 12 to 1 o'clock. We take time. For example, the first week, we'll talk my meeting. The second week, 1 fellow. The third week, another fellow. The fourth week, the rest. Every month, we take time. I give them a book. They just selected randomly and selected a chapter. Then just present. Then I can talking about after they present. I talking about my experience. So they read the book, they present. Then I show my patient. So it's such kind of teaching for my fellow.
Well, that makes sense, because then you can kind of connect the stuff from the book with real life experiences, and it makes more sense.
Yeah, maybe both.
Yeah. We've gone from doing just nerve dissections or explorations and repairs to doing nerve grafts, to doing free functional muscle transfers, to doing, one muscle with 2 functions. And so we're getting more and more complicated. Do you think that there's any big changes coming in the world of nerve surgery? I mean, obviously people have tried nerve allograft, and, it's okay. But what's the next thing, do you think?
Before the question about the future, I like to talk allograft. I don't have any experience about allograft. Although allograft, the company just contact me frequently. But I personally, one is expensive. The other thing is, I don't know. I don't trust that. I believe 3 centimeter or shorter, maybe yes. But more than 3 centimeter, I doubt. And also, as I say, high cost. I think I don't like the patient had the second, because his injury is already first suffering. The next, because the high cost, the operating cost, this is second injury to the patient. So I personally don't like. I use the autogenous nerve graft. This is I think talking about the nerve graft, allograft. I haven't used future.
Yes.
You're talking about the future. Because the futures recently there are many, like AI, like rover, like endoscopic. Remember the my lecture, the moderator asked me about the future. I say you can early diagnosis, for example, brachiopex injury. You can use the endoscope to early diagnosis of the injury nerve because you through axilla along the rib, you can approach the nerve. You just pull the nerve. If rupture, it's very easy to rupture. Apology, you're very easy to know that. If you found it, then you can do early repair. You don't need to do the image study. You don't need to because you already know the result. So you can do early surgery. So the advanced technology, I think is good for diagnosis. But I don't believe they can do nerve repair. I don't believe they can do nerve repair, especially the delay cases, 3 months after or 6 months after. You cannot do that because then scarring.
Scar tissue,
Yeah.
yeah, it's not gonna work. Yeah, that's fair. I have a question for you, which is, you've had experience now of training at Oxford and now being in Taiwan and looking at the two very different systems. What have you found are the differences between the two places, and what have you learned from that?
I can't represent the whole United Kingdom trainees, but from what I was observed is the training philosophies are quite distinct. In the UK, it's more of a competency-based progression, and they have high emphasis on simulation, supervised learning before you can practice independently. This has to do also with the strict time restrictions because, as you're aware, we follow quite closely with the European Working Time Directive. So the residents really work maybe about 48, 52 hours a week. This is in contrast to the residents in Taiwan, where their training philosophy is more apprenticeship-based. So as a resident, you work the work is quite intense, maybe 80, 100 hours, similar to the US. And you get to start in the OR quite early on in your career as a junior resident. And then you progress, in terms of the intensity and the operating experience. I think in Taiwan, they have more exposure to the trauma and reconstructive surgery due to the workload and also due to their insurance system for healthcare, so they get the volumes that come through the door for the residents to operate on. I would say there's no preference in terms of one to the other. I think somewhere in the middle would be the ideal, because obviously you're also talking about work-life balance and you might have to take care of your family at the same time. So
yeah. There's maybe somewhere between 50 and 100 hours. Yeah. But I mean, it sounds like a really amazing training, especially when you're at the level of a fellow, where you get to work with, really experts and do a tremendous volume of surgery and get a lot of experience in a very short period of time.
Absolutely, I agree with that. And also Professor Chuang, I think one thing I noticed about him is even at 76, he's so passionate about what he's doing. And at any moment in time, in clinic, in theater, you can actually see the spark in his eyes. You can know that he's thinking about it, even though it might be the same surgery he has done for hundreds, thousands of times. He's still always thinking, am I doing it right? And is there something that I could improve on? He always go back to the first principle, whether this is actually the way that you can treat the root cause rather than just treat the symptoms. So I think that is what I actually admire about him, and trying to, hopefully in the next time I can learn from and become like him.
All right. Well, on that note, I think we're out of time here, but end the interview there. So once again, Professor Chuang, thank you so much for being here with us on stage and being part of the podcast. Enjoy some delicious Cajun food, and I hope you have a safe flight home.
Thank you. Thank you, Martin, and a good talk. Good talk is mean a good stuff.
Yeah. Well, it was a pleasure.